Hello, everyone. I'm honored today to talk to you about our team project through the Robert Wood Johnson Clinical Scholars Program called Health Engagement Leading to Prevention in Asheville, North Carolina. Our project's ultimate goal is to improve the health of vulnerable residents of a senior living facility here in Asheville and to prevent unnecessary and preventable eviction or hospitalization. We do this through community health worker services. So our project has two main components: direct services and health education to the residents, and for sustainability, training of embedded community health workers who are actually part of the facility community. This is an interdisciplinary project involving medical providers, community nursing, social work, and most importantly, community health workers. Because the particular facility we have targeted typically has medically vulnerable residents with complex social determinants of health needs, there are often psychosocial and medical challenges that often result in eviction, hospitalization, and loss of independence. This not only affects the quality of life and health of the residents, but also leads to excess healthcare utilization and spending. But by providing what we call door-to-door community nursing, the residents are able to remain in their own homes to age in place with improved safety and health. The services that our community health worker and nursing team provide consist of healthy food provisions, health education, and care coordination. This might involve linkage to care to medical services and other resources in the community. Because this is provided by familiar faces with long-standing relationships with the residents, our success is better than I might see personally as a family doctor in my outpatient clinic. These services have been all the more important during pandemic restrictions, as this vulnerable population has more difficulty accessing fresh foods, accurate health information, and even appropriate PPE. The community health workers are on hand to remind residents of social distancing guidelines, use of PPE, and hand hygiene. They can also identify potentially sick residents and connect them to care before symptoms progress in severity. That same paradigm applies to chronic health issues, including substance use disorders and other behavioral health issues that are more amenable to treatment in outpatient settings, but may not catch the attention of the traditional healthcare system until acuity is high. Our 3 community health workers are embedded in the facility, thus reducing the risk and consequences of social isolation, of waiting until a problem gets bad enough. And we've implemented a standardized training for these community health workers so they have a robust fund of knowledge and skills to help our residents. One example of how this all works is hoarding behavior that can lead to evictions and often eventual placement in nursing homes. Hoarding behavior is related to a number of mental health conditions and often worsens under psychological distress, but may not be identified until after it is too late for an intervention that would help the resident age in place. So we include support for managing these behaviors as part of our direct services and care coordination activities. With reasonable effort and spending, these residents are able to maintain autonomy and dignity and even prevent excess community healthcare spending for relocating the resident to a higher level of residential care. Similarly, with behavioral infractions, the standard of care, if you will, may be that the burden of care for a resident with behavioral issues who acts out would be that the facility management staff would have to deal with them. And obviously they have limited training in behavioral health issues and may find eviction or ER referral the simplest reaction. But our embedded community health workers, through relationship building, can intervene before infractions become problematic. Throughout our project, we have collected data to understand how our activities are working to help our residents and to continuously look for opportunities to improve. We have served 116 residents, and with our partner research team at the University of North Carolina in Asheville, we have tracked preventative services, ER visits, we've tracked behavioral infractions, evictions, we've tracked care handoffs, we've tracked cases of COVID. There's been none so far. We're really impressed with that. We've tracked how many food and PPE bags we've given out. We've tracked transportation services, cleaning services, and lastly, we've been tracking demographic and health measures for our residents. We are excited about next steps. Besides continuing our great work at our current facility, we look forward to expanding this community health worker model to other similar senior living facility with medically vulnerable residents. We will also continue training community health workers within the facilities and continue our collaboration with local healthcare providers and county public health systems. Lastly, we will analyze our data to demonstrate the efficacy of our model and seek funding to ensure sustainability. Thanks so much.